We have a great conversation planned for you. With this is Dr. Eric Topol, founder and director of the Scripps Research Translational Institute and best-selling author. A member of the National Academy of Medicine and a practicing cardiologist, Dr. Topol has published over 1,300 peer-reviewed articles and is among the top 10 most cited researchers in medicine. His principal scientific focus has been the use of genomic and digital data, along with AI, to individualize medicine. Dr. Topol's latest book, Super AGERS, which is out this month, dives into the medical breakthroughs and enabling humans to live longer and healthier lives than ever before. He's joined by friend of YC, Othman Laraki, CEO and co-founder of Color Health. For over a decade, Color is focused on providing access and critical healthcare services at population scale. Today, Color is changing the way we approach one of the deadliest human diseases, cancer. The company has built the first vertically integrated and fully owned virtual cancer clinic. Powered by a 50-state oncology team, Color provides proactive, evidence-based care that is accessible to anyone, anytime, at every step of the cancer journey. Prior to Color, Othman founded Mixer Labs, an early Twitter acquisition, and once upon a time was a product leader in the early days of Google. Othman is also an accomplished investor and advisor, working with companies such as Pinterest, Coinbase, Slack, Instacart, GitLab, and others. Please give them a warm YC welcome.
Well, thank you, Gary, and thank you to the YC team for hosting us. I'm really excited to be here today with Dr. Eric Topol. And Eric, you just put out a book about longevity. Obviously, all of us want to live longer, ideally healthier, but there's a lot of information about health, and it's very confusing. That's why people like you are super important. Can you just help us, at least have a framework for how people should think about longevity, how to think about just that broad field and how you make sense of it for all of us, and start with that.
Well, thanks. It's great to be here, having heard a lot about YC for many years, finally to come visit and to meet with you all. So the longevity, some people say it's the longevity moment right now. Why is that? Well, there's kind of different parts of the story. On the one hand, there's some great science going on to reverse aging, and it works really well in mice and rodents, not so much yet in people. Maybe someday it will. I hope so. Wouldn't that be great if we could reverse aging? And we're talking about not just longevity, but giving, for example, stem cell factors called Yamanaka factors intravenously to an old mouse and making it young, not just extending lifespan. So that's a big deal. There are a lot of other shots on goal like that, like the so-called senolytics that take out the senescent cells that are some of them can be quite bad. Some of them are actually good, so it's hard to differentiate. And there's other things like that. So that's the good science. It's venture-backed startups largely. Okay. Then there's the bunk of the longevity companies and the longevity clinics and the Brian Johnson. And this is the crazy stuff. Selling, predatory, no data, just whatever the market will bear. And it's jungleoid. Supplements galore. Claims that they're anti-aging. There's no data whatsoever. Again, if there's any data, it's in a mouse, not in a human. And then you have what I'm trying to advance, which is a safe strategy here and now that's AI dependent. And what we're talking about is you all are very young, but as you get older, you'll be thinking about, I want to live a long life as a healthy person. I don't want to be demented and live to 120. So we want to get health span, and the three ways that it gets curtailed, if not ruined, is by dementia, Alzheimer's, cancer, or heart disease. And we can prevent those now with AI. That's what's so exciting and unique at this moment. So between these three different possibilities, there's a lot of excitement right now. It isn't so much that we're going to prolong life, it's that we can keep people healthier longer. In the book, I only have this one copy, so anybody who wants to grab it is welcome. But the book gets into some patients of mine who are, like, for example, a woman 98 years old, she's perfectly healthy, but all her relatives died, her parents, her brothers, at age 50 or 60. It isn't in the genes. We studied 1,400 people like her. The Wellderly, we called it. The publisher didn't like the term Wellderly. I still like it. So they called it super agers. So basically, we couldn't find anything in their DNA. We did whole genome sequencing, and there's never been a cohort quite like this. So now we have to come to the conclusion that it's either just really good luck, or more likely, it's the immune system. Having a really high integrity immune system as we get older, once you get past 60 or 70, your immune system in some people really starts to get compromised. And that's the key to healthy aging and warding off these three age-related diseases. So it's a different way to use the science of aging story. It's not to reverse aging, it's to take advantage of this new capability we have.
One thing I think that tends to be very challenging or confusing, I think, for a lot of us is, there are a lot of things that correlate, and there are good papers that will show correlations between whether it's sleep or diet or like these kind of like ends of distributions in some sense for and their effect on mortality. But there's a million of those, and whether something correlates doesn't necessarily mean that if you go and do the opposite of it, if not sleeping enough correlates with earlier mortality, then you don't want to conclude that you should go and sleep like 10 hours or 15 hours a day. And I think one question there is like, among all of the different things that correlate, is there a framework that you've used in your work? Like, because one of the things that you do that a huge service to the community is that you constantly review papers and tweet about them and kind of make them digestible for people who don't have either the time or the attention span, in my case, to read through kind of academic papers on a regular basis. And so there's a lot of good science, but that today, that path from science into practice is still very kind of fraught in some ways. And I don't know if there's something a framework that you apply or how you think about things that taking it from there to being like, okay, I'm going to make this decision for myself and change how I behave.
The big three diseases we're talking about take more than 20 years to take root in a person. So if you get them in advance in your 30s, 40s, 50s, that's your big chance to prevent something you otherwise destined might have. So take example of sleep. We've learned a lot about sleep now we didn't know just a few years ago. There's this glymphatic pathway in the brain that gets rid of your toxic metabolic waste each night. So if you don't get enough deep sleep, then you're not clearing this. And if you take medications like Ambien, they actually lead to a backfire of these metabolites, kept in the brain at higher concentrations. People, they think they're sleeping better, but they're actually getting hurt. So at any rate, I knew I was a bad sleeper. I reviewed all the data. I said, I got to start tracking this and then get it up. So I went from less than 15 minutes, which it does get much less as you get older. No, so when you're young, I mean, you're going to get an hour plus, some even 2 hours. But as you get older, I started doing this when I'm in my late 60s, right? And I'm at 15 minutes. This is a really high risk for Alzheimer's. The data are, really unquestionable. We now have ways to measure that with a smartwatch or rings, various rings now that are out. And so I worked on it, to get it up to 45 minutes, 50 minutes. I'm still working on it, but that's a big reduction of risk now from where I was. That's just an example. The diet, the vegetarian choice, very good, Mediterranean-like diet. We've seen that confirmed time after time with randomized trials. And then, the avoidance of ultra-processed foods, really toxic, and they have to something has to be done about that. But we do have choices. And reading labels is really important stuff. And then the exercise is the most important of all. And probably if you're in the midst of what you're doing, you may not have enough time to exercise. I don't know, or sleep. You can't get enough of that, really. Even a moderate amount is extremely beneficial. It wards off, prevents these diseases. So these are the lifestyle plus factors. There's a whole bunch more that we've identified. And they're part of the story, along with the multimodal AI and the new things that we can add to the mix.
So in addition to kind of like, so there's a lifestyle component among the things that like a lot of people here, I'm sure, like we're also very fans of quantifying and collecting data. And, I think there's, especially in Silicon Valley, there's a default bias towards more data is always, we always want more data. And I'm definitely guilty of that. Just kind of curious, what's your take around all these amazing data sources? Obviously, there's the wearables, there's, now full body MRIs, there's easier way to do like a bunch of blood diagnostics, companies like Function Health, what are some others like the liquid biopsies for kind of cancer? What's the right way to think about data sources and whether they're actionable or not?
Yeah, so that goes back to the first thing we were talking about with these longevity companies like function. Peter Attia wrote a book that has been very widely read called Outlive. I don't know if any of you read it, but he has now started a company, Biograph, do a total body MRI in everyone, the same thing for function, all these other tests. There are no data to support any of this. In fact, it likely has more harm than benefit. But the one thing, I reviewed all these 12 companies that you were mentioning, Othman. I do a ground truth Substack. It's free. So if you ever want to get into some of the things I'm reading and trying to make simplified distill for folks, the 12 companies have in common the right idea of getting more data for people, but it's indiscriminate. So they're collecting hundreds of various blood tests and total body imaging. And that's not, there's this thing called Bayes' theorem, right? That if you go into any test and you have a low probability, the chance of you having a false positive or a false negative is just so high. You don't do the test. So here these companies are defying one of the principal things we know in medicine is don't do tests on people that don't have high risk. So basically what I've outlined in Super Agers is that some of the tests that they're doing in these companies are reasonable if they're matched up with the right person. And total body MRI is not one of them, but some of the blood tests, like, for example, if you had a family history of Alzheimer's disease and you have a polygenic risk score high for Alzheimer's, then you might get a p-tau217 blood test. And then you can do exercise and lifestyle to bring that down to pretty much mitigate, prevent ever getting Alzheimer's in your life. So we have tools now, but they're for the right people. If everybody goes and gets this test, there's going to be all sorts of problems in interpreting it.
So how do you, because I feel like there's, you've been one of the earliest kind of proponents of using genomics as part of understanding your general background, prior probabilities effectively, like on a bunch of different diseases. And there used to be also a school of thought that in the early days of genetics, that had a bit of the same posture, which was, the information in genetics might be harmful. You should only test, like if you remember even for BRCA1 and 2, people would say you should only get a BRCA1 and 2 test if you had family history of breast cancer. And now we're saying, like, actually, you probably want to test everyone because these are inexpensive, it's actionable, et cetera. And because I feel that there's a real inconsistency there in the field as we flip from going from saying something should only be used as a diagnostic to something should be used as a mechanism of prior probability setting. And I'm curious how you think about that and brings that transition for different technologies.
Yeah, I mean, I think that you're bringing up an essential point. I don't know if any of you are in the medical community, physicians, clinicians. Are you both? Oh, that's great. But you may know that it's pretty resistant to change. And even when the data is really strong. So what you're just reviewing.
The way I call it is like healthcare doesn't metabolize progress very well.
No, it's kind of tendency towards being ossified. It's like really difficult. But when the evidence is really strong, and this is a great example I go through in the book. So in Iceland, they have sequenced, there's 300 some thousand people in Iceland, and every one of them has been sequenced. It's a really interesting story. They have a company, they're called Decode Genetics, and they gave every person in the country shares of the company so they would be part of it. And then it was sold to Amgen, and some of the people were upset in Iceland. At least they're not in Greenland. Who knows what would happen there, right? Anyway, so they showed that getting the BRCA2 example, if people knew that, they would get 7 years more of healthy life. Everyone should have a BRCA2. It's very inexpensive. You get it done for, $10 or something like that. Of course, if you have a family history, even more. And a lot of men are carrying it. They don't get breast cancer, but they get prostate cancer and other forms of cancer. No less, they give it to their kids. So that's an example of a gene that we should be doing routinely, just like, other types of tests that we do, like a complete blood count kind of thing. But we don't do it. We will eventually because the data are so impressive.
And so for something like, for example, full body MRIs, is your perspective on it is that it's just early and the science needs to catch up to be able to interpret those things properly? Or is it more that there's classes of information that are just not appropriate for population level screening? And
Yeah, so there's a company called Pronovo, which is the big one in this space. They charge over $2,000 and their data are testimonials from the likes of Kim Kardashian, right? They have no data. And when the CEO of the company was asked, why are you pushing this for everyone? He said, well, I have a hunch, I'm not going to wait 20 years. Well, no, that doesn't cut it. You have to show that, for example, it's done for finding cancer. In the book, I go through a friend of mine named Dhruv Kular, who's a physician at Cornell, and he's also a New Yorker writer. And he went ahead this because he's doing a story for the New Yorker, and he regrets ever gotten near an MRI machine. Because what he found was, here he is in his mid 40s, and he has this prostate nodule. And so, then he has to have prostate biopsies every 6 months, every year. And he's now, this is taking over real estate in his brain. And there's nothing wrong with him. And the comments of his colleagues about, you're so stupid to do this test. There are a lot of people like this. And the problem is that when you have a mass showing up on MRI, which is cancer, not just a benign nodule, we're talking about billions of cells. It's not catching cancer early. If you want to catch cancer early, you do this multi-cancer early detection type tests. There's lots of them in the mix. One that's been used in over 400,000 people, most of them for the wrong reason. But that test is a far better for catching something early, microscopic, not seen on a scan. So until we have data, the total body MRI, which is being pushed, to the hilt, it's not a good thing because it leads to lots of, like, I've had a patient who almost died from a liver biopsy of a benign nodule in the liver. People get a collapse of their lung because they have a lung nodule. There's risks of these rabbit hole investigations.
So the model is really more thinking of it as like as new technologies come, starting off targeting the people with the highest priors, and as they get established, maybe and cheaper and knowing what to do with them, they get more permissive until there's a point at which you're like, okay, this is the right long-term population for this service or diagnostic.
Yeah, I mean, if you have a family history of cancer, many of you would have that. You would have polygenic risk scores for all the common cancer. Color used to be color genomics did that really well with a low pass sequence. You would have a sequence like BRCA2 and other so-called pathogenic disease causing type genes. And then if you want to go forward, is it possible I have microscopic cancer? You could then have one of these liquid biopsy, a single tube of blood to see if you have tumor DNA in your plasma. And there are so many companies competing now to do this really well. And the best ones are still not quite out there. The early ones are, still $800 or $900 for that test. But we're going to see it come down to $100 or less in the next couple of years. And that's the way to go. And if you had a high risk for cancer, only if you had a high risk for cancer, you would have this test done, let's say, every year or every couple of years. And that's how you stay ahead of microscopic cancer. But the AI part is to bring all your layers of data. Your immune system, it's very hard to get cancer if your immune system is intact. That's one of the greatest lessons we've learned in recent years. And if you have cancer and if you're not responding to therapy, we just keep dialing up the immune system more and more and more, even vaccines that are personalized for the proteins on your cancer cells. We can even do that now. So we've learned that the immune system is basically the cancer story, right? So if you are found to have microscopic cancer, what's fascinating is some people have that. And then if they get another assessment in 3 months and they have no cancer anymore, what do you think happened? Was it a false positive? Or did their immune system kick in and quash it? Most likely the latter, right? So we can start to do things with the immune system in people who are at risk for cancer. But you have to have the immune system assessed, though, to see that it's not at a high integrity. And as we get older, again, not in this group, but like me, your immune system in some people in their 70s, 80s, it really gets, low protection. And you can just give like a shingles vaccine and that'll bring it up. No less specific vaccines that are now being tested for general immune, dialing it up. Just like we've learned how to dial it down. We can stamp out autoimmune diseases now and achieve cures. We never could do that before.
So I think for a lot of people in the crowd, it's like, people who are, I think, really excited about the applications of AI in healthcare and trying to think about different business models and types of products and services that will kind of meet the opportunity for people. One of the things actually I was mentioning earlier, I love about Eric is that you're one of the few people who's both deep in the science, but also an optimist. And so it's kind of like that combination I think is very rare. I'm kind of curious if you could paint for us in your eyes, like what does the kind of like AI driven or AI based health experience look like? I think you wrote a book about what is it, deep medicine in, when was it, in 2019 was that was published? So
Yeah.
that was way before all this was hot and exciting and seemed obvious. And just kind of curious, like what does it look like? Do we have a AI doctor? Which part of the journey and experience really transforms?
Yeah. So when I tried to project what was going to happen with AI in medicine, the deep medicine book, it was finished in 2018. And the world didn't really know about transformer architecture and where the models were going to go. However, I did talk to the cognoscenti about this, and everyone said we're going to be where we are today in the years ahead, just a matter of when. That this was all incubating, and the ability to generate and edit and reason and all this stuff was going to be. So basically, the book was written with that idea, but without that, it wasn't in hand. And I go back and look at some of these things I put in there. So, oh my gosh, how did I come up with this crazy stuff? It's happening now, right? It was about the doctor-patient relationship. It was about being able to look at scans. So someday you're all going to be taking a retina photo of your own eye, and it's a gateway to every organ in your body. It's not just about the brain. It predicts heart disease and strokes and dementia and Parkinson's. It's part of the multimodal AI story. It's not just blood tests. It predicts liver, gallbladder, kidney disease. I mean, it's years ahead, and people are perfectly healthy. So the only reason we don't have it yet, because the AI sees things we can't see, is because we haven't yet got a company that has figured out how to take a really high quality smartphone photo, a selfie, without having to dilate the pupils, because people don't really want to do that. So that's going to happen going into a dark room with a UV light or something. It's going to happen, and it'll be one of these really big health innovations just waiting to occur. Because right now we have ways to do it, but they're big devices that are expensive, and this is going to go to a selfie mode pretty quickly. But in the book, I said, we have machine eyes, digital eyes that see things that humans will never see. Okay. And we have that. We've had that, but we haven't used it yet in medicine because, it takes a while to get it in gear.
One of the, I think, questions or challenges I think that, and sometimes to me it does feel like a bit of a contradiction in the field, is that we have papers that come out that show that there is a strong association, like for example, Alzheimer's with signal coming out of your in your eyes, but for that to become actionable. So if someone is looking here to say I want to start a company that's going to do that, right? Like we're going to make the healthcare selfie rule them all application. What is the body of evidence or the approach that takes that signal, even if the signal is valid, but makes it possible to really act on it in a way that, similar, like I feel like the liquid biopsy story has been an interesting example there, where the signal is definitely there, but for example, for breast cancer, it only catches at late state. So it's present, but not actionable, at least in the current technology. And so the question is, with these things, if people are wanting to invest their career to build one of these things, how should they think about what's that hill look like? Because I think it's kind of one of these where you think it's about establishing the association, but really you need to establish conviction to act or make a change. And so I don't know how people are going to transition there.
Yeah, so this is another outgrowth of the science of aging that a lot of people haven't thought about. Everybody's thinking we're going to reverse aging, and no, but maybe be great if we do that someday, not any near term. But those metrics, these clocks, so there's a body-wide clock you can get from saliva, methylation, that when it's done in a really good lab, it's highly accurate, amazingly accurate. It will say what is your epigenetic methylation or biologic age versus your actual age. And if it's off by 5+ years, then, something we might want to look deeper into that. Then we have organ clocks. We have a clock from plasma proteins you can get from a tube of blood, not even a full tube, just a few milliliters, you can get up to 11,000 plasma proteins in your blood that can be, with AI, determine tracking your organ age. What's the age of your heart, your brain, your immune system, your liver, and on and on. Then we have this next new layer of data. So what I'm trying to say is, and then we have specific biomarkers. Let's say we want to prove that the retina selfie changes the course for someone's Alzheimer's. It picks up Alzheimer's. Well, you randomize a group to interventions that includes various lifestyle factors, maybe, GLP-1 drugs and whatever. And you show through the metrics that their brain clock is now not outpacing the rest of their body. You show, each of these metrics that the p-tau 217. So we have these breakthroughs, multiple breakthroughs that we can use to prove the intervention, that the AI is doing something. And that's extraordinary. We didn't have any of this a few years ago.
So you think like one of the big changes is that there are these highly measurable endpoints that now are becoming possible to use as definitive endpoints for success along one of these dimensions. Is that the right way to think about it? It's like, okay, if I can show that the biological clock of your heart is slowing in its progression, then whatever intervention I made, and you think we're already at a point where the science is strong enough to be able to credibly use that as the endpoint of improvements?
Absolutely. Having lived through the polygenic risk score era, the earlier era of color, if you had a polygenic risk score and said you had high risk for Alzheimer's, there was a problem, or two problems. One is it doesn't say when. If it was going to be when you're 102, it's like, so what? Okay. The second problem is maybe it's wrong. Okay. That could happen. Now we have all these layers of data as a orthogonal checkpoint. You want to see them all line up. But the other thing we have now is no longer is it yes or no. With AI, we get a temporal plot of when this is going to occur. When are you going to have mild cognitive impairment in your life within a year or two? We could never do that before. This is extraordinary.
In your eyes, is it already worthwhile now to start collecting that data for each person to track that progression? Are we already at that point? Like,
Yes.
For example, should someone start a company doing that?
If you would advise about starting a company in the health space, this precision medical forecasting, multi-layered, multimodal AI is the next big frontier. And we have almost all the parts now. The only one we're missing is a good comprehensive immune system assessment, but that's coming. Everything else is ready to go. And the proof points, you're not going to wait 10 years to see that the person didn't get this disease, or 20 years. We can't wait 20 years, but we can see all the objective metrics going in the right direction. That's people have missed the science of aging, what it's brought us. They thought we're going to just take this treatment, this potion pill, and we're going to be younger. Maybe, I don't know, I hope so, but what really are these metrics. That's what's so extraordinary. We didn't have them. And now we have every layer. I mean, can you imagine? You will know if there's an organ in your body that is making you vulnerable. And of course, maybe it doesn't show up when you're 30, but it might show up when you're 40 or 50 or 60.
It's interesting because also, I think from a therapeutic standpoint, this is a space where, if you look at the last 20 years, it feels that, really the main place where it's been worthwhile for big pharma to invest heavily has been like places like oncology, where you have a relatively small targeted population, extremely high cost, and a relatively rapid clock on the disease, right? Like, so you can, have the evidence, and that whoever's paying for it is going to get, they're paying for some value today. But GLP-1s, I think, have been one of the most interesting breakthroughs there. But there have been very, very few therapeutics, I feel, in proportion, that have gone for long-term health. Kind of curious, do you think that this kind of transition, does that set the stage for a big shift in pharma investments? And is that a place where you think the pharma industry is also going to transition? Or
yeah, so there's hundreds of companies that are using AI for drug discovery, different ways, everything from designing proteins or molecules to accelerating clinical trials. I mean, you name it. But these GLP-1 drugs like Ozempic, Zepbound, are the most impressive drugs to come out in the history of medicine. You may know that they not only help diabetes, and took 20 years, by the way. I tell the story, which is still amazing to me, that it took a scientist in Denmark named Lotte Knudsen, who we just gave a big award to. It took her pushing Novo Nordisk, because the people with diabetes taking these drugs used today, 20 years ago, they didn't lose any weight, 3 pounds, 4 pounds. And so Novo Nordisk really had the first, they had Ozempic, first drug that really worked. They said, why would we test it in obesity? It doesn't do anything. And she said, well, it might work. You got to try it. And she kept pushing them for years and years. They finally did it. And I quipped in the book about if we had GPT-4 then, we wouldn't have wasted 20 years of people walking around with obesity. Then we learned, whoa, it stops addiction, gambling, nicotine, alcohol. It changes the reward circuits in the brain. And people who are taking these drugs, their inflammation in their brain and their body goes down before they lose any weight. And now it's being tested in Alzheimer's for people who are thin, who are at high risk for Alzheimer's. Big trials coming out early next year.
So just to take this example, and you mentioned if they had GPT-4, what could have happened if they had GPT-4 at the time that you think would have accelerated this time frame?
GPT-4, I'm just envisioning this, would have, with the prompt, should we test this in Alzheimer's, would have said, yes, because you're closed-minded, that diabetes and obesity are very different, and you should do it. You don't need Lotte to tell you, keep telling you. I'm telling you, remember, these models are incredibly persuasive, and it would have been persuading them to do it.
So you think it's more persuasion as opposed to, I thought you meant it would make it possible to test 50 hypotheses where the data might have been sitting there, but no one was really, it didn't seem worthwhile to look at the data. But if you have a lot of reasoning that's available.
I think it would have given plausible biologic reasons why it would work in obesity and not in diabetes. And it wouldn't, we as people are very narrow-minded about, we don't have never enough imagination. That's what's so unique about the world of AI right now. It's limitless. You can't have enough imagination. So back then, and for many years, they were just, mentally constricted about its expansive use. And we lost 2 decades because of this, which is amazing when you think about it. So, maybe GPT-4 had it, if we could, again, a time machine, maybe it wouldn't, but I'm just thinking the way it performs now, it's likely it would have come up with a case to try it. That's all they had to do, is just try it, because it was magical. People just lost weight like we've never seen, and safely. I mean, I've been involved with other drugs that were supposed to be anti-obesity, but people tried to kill themselves, or other problems that the drug didn't work. So this was breaking one of the most difficult barriers in healthcare ever. Because we never had a drug that works. And by the way, there's one other thing that's really fascinating, Othman, I think but every drug we have, the side effects track with the efficacy. So you don't get a free lunch of the efficacy without the side effect. This is the only class of drugs that the first few weeks you get some GI problems, and then they go away. But the efficacy doesn't ever go away, which is part of the problem too, because you're like forever drugs. So you have to figure out a way to wean people so they don't have to take these for the rest of their lives. But this is an amazing drug class, and I tend to be very anti-pharma generally, but this is unusual, and it's a precursor. The gut hormones, which what these drugs are, they mimic our gut hormones. There's now 10 more to add to the list, and they're all going into clinical trials, combinations, potent. We got triple receptors, quadruple receptors. I mean, this is just the beginning of the gut hormones. They talk to the brain directly. Some of them get in the brain far better than the current one. And they talk to the immune system, and they control the immune system, which is the basis for healthy aging, right? So most of you someday will take a pill of one of these gut hormones someday. Just remember today, fast forward 15 years, you'll probably be taking this, most likely. Because look, when I was in medical school, we only knew there was one gut hormone, it was insulin. We didn't know anything else. And now look what's happened. It's exploding. and our ability to make pills. The pill works as well as the injectables for people who don't like needles, even though they're relatively, I mean, they're painless. But yeah.
That's pretty amazing. I feel like every week a new paper comes out with the efficacy of GLP-1s in some different aspects of health. And
Yeah.
maybe pivoting into the kind of like, and I'd love to open it up for questions after this. I'm kind of curious about the clinical access and the healthcare experience of individuals, like projecting like out, 5 years or 10 years, whatever, you're optimistic on timelines. So, in your words, it'd be 5 years, but like
Yeah.
but what's your feeling about like, are we going to have like, a cardiologist like you equivalent, like looking at every one of my heartbeats on my Whoop or Aura, and
Yeah.
like, is it going to be like an abundance of like, what's going to be our
Yeah.
healthcare
I
like?
mean, the vision is each of us will, if you want, it's an option. We'll have a virtual health coach and it'll be cued into what are your risks and vulnerabilities. And it'll be, really zooming in on that. And it will be advising you all along the way about something that's changing. I mean, we were talking on the ride here about set points in data. And you saw recently how Joe Biden's prostate cancer was diagnosed and like all of a sudden. Well, it probably wasn't all of a sudden. The problem is when lab tests are reported, you've seen your lab test and it's an asterisk only if it's abnormal. Well, that's all the doctor ever looks at. No one looks at trends. That's what AI does so well, call it set point. And undoubtedly, if you go back to Biden's medical records, I haven't done it yet, but probably will look at it hopefully soon, you'll see that something was going on with his PSA. And it was in the normal range. But that's where the coach is going to say, Othman, we're seeing something in your whatever test. And we think we've made an appointment for you to do this. And that's what's going to happen in the years ahead. Yeah.
One thought on that too is like, I totally agree. I think it's one of these where just seeing, for example, in my own experience, like a lot of these, I mean, like actually PSA is a great example there for prostate where, there's signal in the absolute level, but also in the acceleration. But for example, in my personal experience, I literally remember this 10 years ago. I've been going to the same at PAMF down in Palo Alto, and so I have all of my blood tests from going back like 25 years. And then one day I plotted them, my L from my LDL, and noticed like it's just a linear progression. It's like literally you can draw a line. And at the time I was like, oh, but I think by 45 I'm going to cross the elevated LDL, and literally 10 years earlier, like
Yeah.
that's exactly when I crossed it. It's kind
Yeah.
of
And you are obviously data centric in thinking, but people who are not are going to have AI support for all of this. And it's really exciting.
so in your mind, it's less about, and I don't want to put words in your mouth, but my impression is that it's less about using AI to dynamically superintelligence its way to creating novel associations for each person and some magical black box, but rather it's infrastructure that can do the practice of care or like the reasoning of healthcare much more readily and on an ongoing basis, right? Like, is that a right way to
Yeah.
think about it? Or
It's taking low tech stuff like lifestyle factors, which most people don't adopt because it's the same prescription for the entire human species. But now it's saying, this is your risk, much higher chance that you'll follow those, monitoring that, and now adding this other, really high tech
Mhm.
layer for you. When things are particularized to a person, the chance of making a difference is so much greater.
So thanks for setting that framework. Maybe we'll open up to questions and we'll take it from there.
Yeah, so I have a chapter on mental health because it's so darn important and the interactions with physical health, how we handle anxiety, stress, depression, they're critical. And if we use them in the right way to amp up our protection, like exercise and other lifestyle things, it's really good. We've seen some, as you know, I'm sure, some real advances of AI helping people with depression, anxiety, and that looks really promising, even a randomized trial. We need even better evidence because they use often wait lists, which isn't the best control group. We need better, more rigorous studies, but it looks like we have this profound shortage of trained psychologists, counselors, psychiatrists, and we need AI to kick in. We need it badly. And it looks promising. And one of the most interesting things that I've ever seen in the mental health is how we are much more entrusting of an AI with our deepest secrets as compared to a human. Who would have guessed that? So the mental health thing is really important. We got to get this right, and we should be putting a lot of resources into it because the burden of these mental health conditions keeps growing, and our inability to support folks is just really a horrible mismatch.
One thing I've seen in longevity field is that the use of animal data, like I've never seen in medicine before. Typically, we look at animal experiments as maybe hypothesis generating, but far from clinically actionable.
Yeah.
And even the longevity interventions that we tested in large animals and successful in all animals, and maybe due to social media, people know about things like interventions testing program. What are your thoughts? Like, how do you convey uh, belief or skepticism in animal experiments, and to what weight do you give them?
Yeah, I mean, I think most of the animal experiments were only that we got the mouse to live longer. Only, some of the most elegant work, like Altos Labs and a couple others, are showing that the organs, reverted to a younger state and microscopic improvement. But the problem we have now is that jumping the gun. So we have the big time investors, these are the multi-billionaires that when they were young, they wanted to be rich. And now they're rich, they want to be young. And these people are pouring in billions of dollars. And these are the biggest, richest people in the world. And they are basically extrapolating things like rapamycin example. Rapamycin works pretty well in certain animal species, never been shown to help humans. It suppresses the immune system and it's unpredictable. A low dose in a certain person, particularly of advanced age, could really put them at risk for cancer, take their guard down, right? We have no way of measuring it now. So the jumping the gun is that you could be taking this and have a rapamycin leaderboard where all these people are taking it. Everyone's like a different dose. I take it once a week. I take it every day. This dose, I take it every other day. Nobody knows because there's no data. This is incredible to me. Jumping the gun and putting people at risk. And, you've got this is kind of like the bro science, we got the bros that live around here and in Austin, Texas. And what they do is they have a big fan club and they tell you, I'm taking rapamycin. You should take rapamycin. Well, yeah, show me the data. That's all I want to see is human data that it's safe and what dose and does it change these metrics of aging? The only thing that's changed epigenetic biologic age so far of all these things we talked about today, guess what? The only thing that's been rigorously demonstrated to slow a person's body-wide aging, and it isn't rapamycin, exercise. The only thing, right? That's for free. Go for a walk, but nobody's going to sponsor that one.
Start a walking company.
Yeah. The problem with all these things is they always have a mix of some good things and then some completely cuckoo things that are baseless things, right? So, for example, Brian is a real proponent of sleep health. That's good. Okay. There's data to support that. But then he, would get plasmapheresis from his son, uses a penile sensor and compares it with his son for a number of erections per night. All kinds of crazy. He was taking 157 supplements. Now he's saying he's only taking half as many. I mean, there's no supplements that help people, and on and on and on. So the problem is certain parts of his story are, and then his exact number of calories per day with this whole staff that prepare all his meals. It's something that he has a whole culture, a cult of people in the don't die group, right? And there's nothing to it. So it's a real extreme example of the problem. The problem you're bringing up is it doesn't take $100 million to do a clinical trial. What we're talking about is use these metrics of aging. You propose, I have a way to reduce age-related diseases. Do a trial in 1,000 people and show that your intervention led to the clocks all moving in the right direction. That would work. That would likely get FDA clearance. So you don't have to spend hundreds of millions. We're talking about it in the single digit millions to do the right trial, to test something. Great question. Because, for years as a cardiologist, we would always say to our patients, we're concerned about the cardiac risk. And there's one study to suggest that risk was probably not yeah, one study. Yeah, which to me is totally inadequate. This exemplifies this bro science, and a lot of people. First we had years of TV ads for low T syndrome, right? everybody had low T. And then now we have this, and it's a mess. I still think there's risk, and there's no reason to be taking testosterone unless you have specific symptoms related and a critically low level. And most people shouldn't even have their levels tested, really. So we have, just a unfortunate situation.
I'd love for you to riff on this sort of tension between two things that I've heard you bring up during this talk. On one hand, you described, I think accurately, that the GLP-1 agonists are the most aggressive class of drugs that's ever hit the market. Simultaneously, on last Friday, we saw Lars, with CEO and Novo Nordisk, get fired after a 60% growth on market cap. If indeed Novo Nordisk had come out with Ozempic successfully 20 years ago, it seems like they would have gotten to ride that wave for way longer. The advent of technologies, the reversing of e-realms law, makes it such that copycat or follow sort of Me Too drugs hit the shelves faster. Is it your intuition that market pressures coming online faster makes the underwriting of new drugs a hell of a lot harder?
Yeah, I mean, you obviously know a lot about this space because you already know about Eroom's law, the reverse of Moore's law, and all this other stuff. Yes, the answer is that in the case of Novo Nordisk, they own this space. And what happened is the market is the US. And we have now well over 10, 15% of people taking one of these GLP-1 drugs. And the shift is going more to Lilly because even a randomized trial has shown that Lilly's drug is far more potent than the Ozempic. So the problem with Novo Nordisk is they rested on their laurels of the first drug, and everybody knew their song and and they had the market, but they didn't keep iterating to the next best. And so they let tirzepatide and the U.S. market, which is what controls their earnings, they've taken a big hit. So they're on it. They have the Novo Nordisk now is the biggest research foundation in the world. With all the money, they sock away all their profits into research. So they're going to they'll be going back and forth. It's not going to be a Lilly world for that long. But for right at the moment, that's what they should have just been going to the next generation compound, gut hormone or combination or whatever. And they just let it open for a US company to get an advantage.
Okay, we'll take one last question. Go ahead.
You bring up an important point is that we have to do much better to partition that high risk and also set the bar, 5%, 10%, what is that high risk? But the real point here is that like for heart disease, we just published a paper, meta prediction of heart disease, and we show that you can take the low risk people and now reclassify them to high risk based on much more discriminate power. So we have to do better, but I would never subject people to tests that are not well founded by evidence unless they came into this high risk category. Because perfect example, mammography. How many women in their lifetime will ever develop breast cancer in their lifetime? What percent? Anybody? Well, that's close, 12%, 11, 12 max in this country. And why do we have every woman suggested they get a mammogram, whether it's age 40 or 45, every couple of years? And do you know what the rate of false positives are with unnecessary biopsies and recalls and the whole works? This is ridiculous because we don't partition high risk. We have a population dumbed down mass screening where we treat all human beings like cattle, right? We need to be smarter than that. And that's the way we screen for cancer today. That's why I have a whole chapter in the book about rebooting cancer. How dumb can we be? You know how many billions of dollars we waste just for mammography, no less colonoscopy? Every single cancer screening, we don't account for a person's risk. And I think we have more young people now than ever who are developing colon cancer in their 20s and 30s, breast cancer, and other forms of cancer. They don't even fit into these 50-year-old, 40-year-old type of recommendation. We have to be smarter than that. Yeah.
That's a great note to finish on.
All right.
Eric, thank you so much.
Thank you.
I highly recommend everyone read Eric's book. If we were supposed to have a stack here, but I don't think it got delivered, you send me an email, othman@color.com, by tomorrow. We'll get the book to you by the end of the week. So, but Eric, thank you so much for doing this. Gary and YC team, thank you so much for hosting.
Thank you, Gary. Really, all of you. Thanks.